All right, let's break this down. When you hear diabetes insipidus or DI on the NCLEX, I want you to think about one thing. Water. This isn't about sugar like its more famous cousin. This is all about a major problem with your body's water balance. Specifically, it's a disorder where your kidneys are unable to conserve water, leading to massive amounts of urine output. Imagine a faucet in your body that's stuck open, constantly draining your water reserves. This condition is primarily linked to a hormone called antidiuretic hormone, or ADH. When ADH isn't working right, either because it's not being produced or your kidneys are ignoring it, your body just can't hold on to water. ADH, which is also called vasopressin, is your body's don't pee hormone. It's produced in the hypothalamus, a small region at the base of your brain, and then it's stored and released from the posterior pituitary gland. Its main job is to travel to your kidneys and tell them to reabsorb water back into your bloodstream. In diabetes insipidus, this crucial communication system breaks down. Without that ADH signal, the kidneys don't get the message to save water. Instead, they just let it all go, resulting in the excretion of large volumes of very dilute, watery urine. Let's clear up a huge point of confusion right now. Diabetes insipidus, or DI, and diabetes mellitus, or DM. The names sound similar, and they both involve the three P's: polydipsia, which is intense thirst, polyuria, meaning excessive urination, and sometimes polyphagia, which is excessive hunger, in DM. Diabetes mellitus is a problem with insulin and blood sugar, or glucose. Your body either doesn't produce enough insulin or can't use it effectively, leading to high blood sugar levels. Think M for mellitus, M for metabolism of sugar. It's a metabolic disorder. On the other hand, diabetes insipidus has absolutely nothing to do with blood sugar. A patient with DI will have a normal blood glucose level. In diabetes mellitus, when blood sugar is high, the excess glucose spills into the urine. This makes the urine concentrated and heavy, so it will have a high specific gravity. In stark contrast, the urine in diabetes insipidus is incredibly dilute because it's mostly just water. It will have a very low specific gravity, almost like pure water. So, remember, DM urine is sweet and heavy, with high specific gravity, while DI urine is tasteless and light, with low specific gravity. When you see a question that gives you symptoms like extreme thirst and urination, the very first lab value you should look for is the blood glucose. By focusing on these three key data points, blood glucose, urine specific gravity, and serum sodium, you can confidently and correctly distinguish between these two very different conditions on your exam. There are two main types of diabetes insipidus you absolutely must know for the NCLEX, and they are defined by where the problem originates. The first and most common type is central diabetes insipidus. In this case, the problem is in the brain. There's damage to the hypothalamus, or the pituitary gland, which means the body isn't producing or releasing enough ADH. Think of it like the factory that makes ADH is shut down. This can be caused by head trauma, a brain tumor, infection like meningitis, or surgery on the pituitary gland. So, when you see a patient in an exam question with a history of recent brain surgery or a head injury who suddenly starts producing massive amounts of urine, your alarm bells for central DI should be ringing loudly. The second type is called nephrogenic diabetes insipidus. The nephro prefix tells you the problem is in the kidneys, the nephron. In this scenario, the brain is doing its job perfectly. The hypothalamus and pituitary are making and releasing plenty of ADH. The hormone travels through the bloodstream all the way to the kidneys, but when it gets there, the kidneys just ignore it. Let's walk through the pathophysiology step by step. In a healthy person, if the body starts to get dehydrated, serum osmolality increases. This triggers the pituitary to release ADH. ADH then acts on the kidneys' collecting ducts, making them more permeable to water, so water is reabsorbed back into the blood. In central DI, this first step is broken. No ADH is released. In nephrogenic DI, the ADH is released, but the kidney part of the process is broken. Alright, so when you're faced with an NCLEX question, you really need to be able to spot the classic signs and symptoms of diabetes insipidus right away. The two cardinal symptoms that basically scream DI are polyuria and polydipsia. Let's start with polyuria. This isn't just urinating a lot, it's actually an extreme massive output of urine, and we're talking anywhere from 4 to 20 liters per day. the urine will be super pale, almost colorless, like water. That's because it's so dilute, with a really low specific gravity, usually less than 1.005, and low osmolality. A patient might complain that they're constantly in the bathroom, even waking up multiple times during the night. This is called nocturia, which leads to severe fatigue and sleep deprivation. Now, all this massive fluid loss directly leads to the second hallmark symptom, polydipsia. This is an intense, insatiable thirst. Patients might feel compelled to drink huge amounts of fluid, and they often prefer ice-cold water. You might notice they carry a water bottle everywhere they go. And here's a really important safety point. If the patient can't drink, for example, if they're unconscious or they have an impaired thirst mechanism, they are at a super high risk for developing severe dehydration and life-threatening hypernatremia very quickly. Beyond the big two, you also need to watch for signs and symptoms of dehydration and hypernatremia. So look for dry mucous membranes, poor skin turgor, where the skin stays tented when you pinch it, hypotension, which is low blood pressure, and tachycardia, or a fast heart rate, as the body tries to compensate for that low fluid volume. Neurological symptoms are also a huge red flag and are related to the high serum sodium, or hypernatremia. These can go from irritability, confusion, and lethargy all the way to seizures, coma, and even death if you don't treat it promptly. So let's create a memory trick for this. Think of the D's of DI. First, you have diuresis, which is the polyuria, the massive output of dilute urine. This leads to the body being dry inside, causing dehydration and drinking a lot, which is polydipsia. This can result in a decreased blood pressure and dangerous levels of high sodium in the blood. Okay, so let's say you suspect diabetes insipidus. How do you actually confirm it? The NCLEX is definitely going to expect you to know the key diagnostic tests. The first step is basic lab work, checking both the serum and the urine. You'll want to look at the serum sodium and serum osmolality, and both of these will be high because the blood is concentrated from all that water loss. Then you'll check the urine osmolality and urine specific gravity, and both of these will be very low because the urine is super dilute. The definitive test for diagnosing DI is called the water deprivation test. This test is done under really close medical supervision since it can be dangerous. The patient is deprived of all fluids for a set period of time, usually several hours. Normally, the body would respond by releasing ADH, and the urine would become very concentrated as the kidneys try to conserve water. But in a patient with DI, they'll keep excreting large amounts of dilute urine, even when they're not drinking anything. Now here's the really crucial part of the water deprivation test that helps you tell the difference between central and nephrogenic DI. After you confirm that the patient keeps producing dilute urine even while dehydrated, the next step is to give a dose of ADH, usually desmopressin, which is a synthetic form of ADH. If the patient has central DI, which means they lack ADH, giving them this synthetic ADH will basically fix the problem. Their kidneys will suddenly be able to respond, and their urine will become concentrated, with a significant increase in urine osmolality. However, if the patient has nephrogenic DI, meaning their kidneys are resistant to ADH, giving them desmopressin won't really do much. The patient will keep producing large volumes of dilute urine, and the urine osmolality won't increase significantly. So, as a nurse, your role in managing a patient with diabetes insipidus is really critical and centers on safety and restoring balance. Your number one priority is fluid and electrolyte management. You'll be responsible for meticulously monitoring intake and output, which means you have to accurately measure every milliliter of fluid the patient drinks and every milliliter of urine they produce. You'll also need to keep track of their daily weight. A sudden weight loss is a big red flag for significant fluid loss. Frequent vital sign checks are a must, especially watching for hypotension and tachycardia, since those are signs of hypovolemia. For patients with central DI, the primary medical treatment is hormone replacement therapy. The medication you need to know for the NCLEX is desmopressin, also known by the brand name DDAVP. This is a synthetic form of ADH, and it can be given orally as a nasal spray or intravenously. Your nursing responsibilities include administering this medication as prescribed, and, just as importantly, monitoring for its effectiveness. You'll know the medication is working when you see a decrease in urine output, an increase in urine-specific gravity, and a normalization of the patient's thirst and serum sodium levels. A crucial point to watch for is the risk of overtreatment with desmopressin. If a patient gets too much of the medication, their body will retain too much water, which can lead to the opposite problem: fluid volume overload and a dangerous drop in serum sodium, known as hyponatremia. The signs of this include headache, nausea, confusion, and weight gain. This condition is called SIAD, or Syndrome of Inappropriate Antidiuretic Hormone, which is basically the opposite of DI. So, you're constantly walking a tightrope, giving enough desmopressin to control the DI without tipping the patient over into fluid overload and hyponatremia. For patients with nephrogenic DI, desmopressin just won't work. The treatment approach is different. The goal here is to reduce the amount of urine the kidneys produce. This often involves a low-sodium diet to decrease the solute load that needs to be excreted. Thiazide diuretics, which sounds kind of counterintuitive, are also used. They work by causing a mild state of sodium depletion, which encourages the body to reabsorb more water in the proximal tubules of the kidneys, before the part that's resistant to ADH. Understanding diabetes. Insipidus is crucial for NCLEX success. Remember the key differences between central and nephrogenic types. Recognize the classic symptoms and know the appropriate nursing interventions. For more comprehensive NCLEX preparation and additional resources, visit www.brispainternational.com. Good luck with your studies and your nursing career.